Welcome to this CTSNet video on echo interpretation. My name's Joel Dunning. I'm absolutely delighted to be here with Ademola Abiosi from the North Ohio Heart Center. Ade, welcome.
Thank you very much for the introduction, Joel. My name is Ademola Abiosi. I am a consultant cardiologist with North Ohio Heart. The goal today is to talk about echo applications with slant towards surgeons and the usefulness and applications of basic echo and TEE for surgeons. So the mitral valve, surgeons are obviously more familiar with the mitral valve because they see it in real life. But it's not just the valve; it's a structure, and the structure itself composes of the annulus, the leaflets. There are chordae, the primary, secondary, and tertiary chordae, and the papillary muscles, and even the ventricular function, the geometry of the ventricle. All these things is what we call the mitral valve complex, and they all interplay to affect the normal function of the mitral valve. And to the right, you can see the schematic that shows you the anterior leaflet and the posterior leaflet. You can see the chordae tendineae. This is the anterolateral papillary muscle and the posteromedial papillary muscle. And of course, the geometry of the ventricle. All these things constitute the mitral valve apparatus. So how do we evaluate the mitral valve, especially mitral regurgitation and mitral stenosis from a surgeon's perspective? When the surgeons open the left atrium, they don't see what we see when we do the TEE. They actually see something like this. I think the one that's really the mainstay is the Carpentier classification. Is that right, Joe?
Absolutely, yeah. We're A1, 2, and 3, and P1, 2, and 3, and secretly you don't really see different cusps on anterior, but posteriorly you can really see that. So yeah, the one on the right is the one we see.
Yeah, and that the next slide is actually gonna I'm gonna come back to that. But so this slide shows you the surgeon view of the mitral valve. The aorta is aortic valve is anterior here, left atrial appendage is to the left here. And here, you can see definite scallops of the P1, P2, and P3. The anterior leaflet doesn't have that well-defined scallops like Joel said, but they still labeled as A1, A2, and A3. So the job of the echocardiographer in the OR is to use different views of the TEE, which we usually go. The four basic views that I will come to later will be what we call the 0-degree views. That is going to be the 4-chamber view. So remember, this is the mid-esophageal that we're taking all these pictures. So this 0-degree view will be the 4-chamber view. Okay.
So 0 degrees is straight up and down the esophagus, basically.
Yeah, right? We can see right here. That's where we're slicing. This is in relation to the valve here.
Yeah.
Okay. I will show you in relation to the esophagus on the next slide.
Yeah.
But so when we change the angle to about 45 to 60 degrees, that's what we call the commisural view of the mitral valve. And these are the scallops that we see. We see the P1 and we see some of the A2 and A3.
Do you twist it to a fixed degrees, or do you wait till you see the right view on the echo?
Oh, we change the degree, so it doesn't have to be a fixed degree because the anatomy is different for different patients. So sometimes it might be for some patients, it may not be exactly at 0 degrees when you see that 4-chamber. So you have to make some adjustment. It might be 15 degrees, it's not exactly like that. So you play with it until you see what you're looking for. The next one will be the 2-chamber view, or what we call the 90 degrees view right here. And then that shows the P1 here. We have the A2 scallop in the middle. Sometimes you might see more than A2 in the middle, and then you have P3 to the left here. And then my favorite view, because it's very simple and it's not very confusing, is about 120 view, because there you can see the LVOT. And the scallop that you see there will be the A2 next to the aorta, and the P2 scallop will be to the left. So we're going to see this. So this is the probe, the TEE probe right here, and in relation to the heart. And those are some of those views that I talked about. So we rotate the cursor from 0 to 60 to 90 to 120. And then we'll be able to see those views that we talked about. You've seen this. This is just a label of those scallops. So I'll quickly go through Carpentier's classification. You guys, being surgeons, you're probably more familiar with this, but basically it's classified based on the etiology, the cause of the valve disease, what kind of lesion does it produce, the result of the disease itself, and then what is the result of the lesion, what kind of dysfunction does it produce. So like the cause of valve disease could be degenerative, it could be infectious, it could be coronary disease with ischemic MR. What is the result of the disease process? It's either there is caudal elongation, caudal shortening, or annular dilatation. And then the result of the lesion itself is that it affects the closure of the mitral valve with relation to the mitral valve annulus. So this here is the classification from type 1 to type 3. Type 3, there's type 3 and type 3B. Now, Joel, if I'm getting too much into this, you can let me know so I can sort of move to something else since I'm talking to surgeons.
We love this bit.
Okay, keep going. So in type 1, there is normal leaflet motion, okay? So the leaflet itself, it's moving normally in relation to the annulus. But maybe because there's a leaflet perforation or annular dilatation, then you have residual mitral regurgitation as a result of that. So the approach is going to be different.
Yeah,
for
so
type 2,
ischemic mitral regurg, isn't it?
Correct?
Yeah.
For type 2, there is excessive leaflet motion. So like the common thing will be like things like mitral valve prolapse, degenerative mitral disease, endocarditis or trauma. Type 3 is actually divided into 2. There is where you have restricted leaflet motion, either in diastole or in systole. Like in rheumatic valve disease, there's restriction of the leaflet motion in diastole leading to mitral stenosis. Or if it's in systole, which is the ischemic heart disease, where you have tethering of the mitral valve that is responsible for the residual mitral regurgitation. So once again, normal leaflet motion in type 1, those are the common causes to the right there, okay? The result of the lesion is annular dilatation, there might be leaflet perforation. Remember, the mitral leaflets are normal in motion in respect to the annulus for type 1. All right, so this will be an example of such, because here there appears to be a leaflet perforation. You can see to the left here, this is definitely not a normal leaflet. And then when you see the jet of the mitral regurgitation, you see a central jet, but you also have something that is coming eccentric all the way to the right here. Okay, so that's the 4-chamber view that shows you what a type 1 lesion looks like.
Yeah.
This, now we've changed the angle of the TEE to about 60 degrees view, which is called the Bicommissural View. Here gives you an advantage of looking at not just the leaflet itself, but you can also appreciate some of the chordae. So that's why it's called the Bicommissural View, because you can see the mitral commissures. And you can see that central jet of mitral regurgitation that we talked about. There seems to be an eccentric component all the way to the right here. Okay.
Yeah.
All right, what about, so that's 2-chamber view. So of course you need to get multiple views to be able to appreciate this, and this shows it very well. You can see that this, when you compare it to the right, to the image on the left, you can see where the jet is actually coming from. So despite the fact that the leaflet itself is quote unquote normal, but there's been leaflet perforation leading to that mitral regurgitation. Let me not forget to mention, as you can see here, that these images are supplied by my colleague and mentor, Dr. Lisa Sugeng, at Yale University Echo Lab. So you can see all these very beautiful images there. Okay. So type 2, the leaflet motion is not normal. There's actually increased excessive leaflet motion. The one that we're all familiar with will be the degenerative mitral valve disease, like mitral valve prolapse. Okay. And that is the one that that it's actually very critical to be able to identify the area of the prolapse to help the surgeon in terms of doing an excellent repair, because for more than 90% of the time, some of these can be successfully repaired without having to replace the valve. And you know better than that than I do. Right, Joe?
Yeah.
Okay, so this will be an example of that. You can see this is our TEE up here. We're going at about 0 degrees. So that's that 4-chamber view that I talked to you about, where you can see the A2 and then the P2 sometimes, or it might be the P1. But you can see, I think the other ones will probably show you that there is this eccentric jet of mitral regurgitation that is directed in the opposite direction, suggestive of prolapse on that valve there.
Yeah, and that's the posterior leaflet, and to the left was anterior.
Yeah.
Yeah.
So here, just the same thing, but right now we're at about 60 degrees, and that is the mitral commisural view. You can appreciate that it's still an eccentric jet, but
so you've got a bit of anterior leaflet in the middle, and then you've got posterior leaflet on the left and the right, haven't you there?
That is correct. That is absolutely correct. So you have the anterior leaflet right in the middle. Sometimes it's the A2, sometimes it's A2, A3, A1. You might be able to see the whole of the anterior leaflet, but the P1 will be to your right and P3 to the left. So yeah, that is exactly correct. And that is what this is showing you here. On the top of the screen, you can see that you see the P1 here, and then you see some of the A2 scallops right in the middle, and then you catch the P3 over there. Okay, that's why I put that cartoon up there. Here we are at that 120 degrees view that I said I like that a lot, because with that, when you slice it like this, you see the A2 and you see the P2. And you know, majority of the prolapse is on the P2. So if you're able to confidently diagnose that, half of your work is done. And to the left of the screen here, you can see that the jet is anteriorly directed. This is the A2 scallop. The jet is going like this. So that suggests that there is P2 prolapse, which is confirmed when you do, so this is a biplane view. You can see the jet is going anteriorly, and this is your P2 prolapse there. So this, and you can see the LVOT right here. So this is a very good view. If you have any questions about A2 or P2, that is what we generally
that's why they say the murmur's louder at the front, because that jet's going forwards, isn't it?
Correct. The murmur is, yeah, the jet is going forward. Yeah, absolutely. Okay. So quickly, you know, type 3A, like I said, there's restricted leaflet motion in diastole. So that's mostly mitral stenosis. I will talk about mitral stenosis later on as we go along, but you know, you can have leaflet thickening, commissural fusion, and just a lot of calcification because of rheumatic valve disease. But I think type 3B is the other one that also causes a restricted leaflet motion in systole, and that is mostly due to ischemic mitral regurgitation. Very difficult to treat because it's due to tethering of the leaflets as a result of ventricular modeling from, let's say, big anterior or inferior myocardial infarction that tethers the leaflet. And I am not familiar with the extensive surgical literature in terms of whether you should correct this when you're doing bypass or not, but basically that is the other classification. And an example of that is this 60-year-old female with ischemic heart disease who also had some alcohol consumption. She's been treated for heart failure for many years, but she's been in and out of the hospital several times in the last year. So she's not deemed to be a candidate for transplant. And this was her echo before repair. And you just get a sense that let me see if I can find my cursor. This leaflet is kind of tethered down, you know, it's the plane of coaptation is actually below the annulus. That's, you know, tethering from old myocardial infarction. So there's nothing wrong with the leaflet itself. There might be some annular dilatation, But just because of that leaflet tetraene, you can see the degree of mitral regurgitation that this is causing for you. So this is not something that you can just say, let's repair the valve, because there's nothing wrong with the valve. So for the most part, and Joel, you can probably talk about this. I think it's, they just put like an annuloplasty ring to sort of undersize and reduce the degree of annular dilatation. Is that correct?
Yeah, absolutely. And and we're going to talk about how to estimate the severity of regurg in a bit, aren't we? But a wide jet and a long jet, in summary.
Okay. So that is quickly in summary. What we just talked about is that the 4 views that we really look for when we're looking doing the TEE. There is the 4-chamber view, which is here, and like you mentioned, there is the A2 and P2 scallops there. That's usually at about 0 degrees. There is the commisural view. That's the other one that we talked about, where you have the A scallops in the middle. It could be A2, and then you have P1 here to the right, and then you have the P3 to the left. Okay, that is the commisural view. So the third one will be the 2-chamber view. Okay, 2-chamber view gives us a long look at the anterior leaflet, so you can even see the A1, A2, or sometimes the A3, and then you see the P3 scallop. And this is the last one that I talked about, where you see the LVOT. So this will be your A2, and this will be your P2. That's about 120 degrees. So that's the summary of everything that I've just talked about. Okay, and here to the left, it just shows you how we slice the those things. And this is the real-time images of the 4-chamber view in 0 degrees, anterior and posterior. This is the commisural view at about 60 degrees. That is the A scallops in the middle, right there. Sometimes A2, A3, A1, P3, P1, P3, right there.
And maybe for surgeons, that's the bit that they get a bit confused about when there's a bit of anterior and a bit of posterior. But I suppose it's looking at the angle, isn't it? And to spot when your anaesthetist is doing that, or your cardiologist. I suppose it's just getting used to it.
Yeah. So when we change the angle to 90 degrees, you have this long anterior leaflet. It could be A1, A2, A3. You can even see all the 3 scallops. And this is the P3 scallop that we see on the posterior. Could be P3. And then this is your A2, P2 scallop. A2, P2. Okay? So that is a summary there. What about 3D? 3D is the way of the future now. That's to actually show the surgeon what they're going to see when they go to the OR. This is the aortic valve on top of the screen there. So this will be the anterior scallops and the posterior scallops. That is your classic surgeon's view. And let me see if, so this is what it looks like here. You can see it helps to determine the lesion, because you can see there's like a P1 here. The P2 will be right in the middle here. Okay. This here shows like just this is a very degenerative valve. You can see it involving all the posterior scallops. Okay. So for the 3D, you don't need to change any angles or do anything. It just shows you how it is, the way the surgeon is going to see it. That is, so that has really helped in terms of mitral valve repair, even prior to surgery. I'm not going to get into the details of this, but basically, this is how we acquire the 3D. We get a biplane view, we zoom on the mitral valve, and then we acquire the 3D, and then we change, we rotate the angle so that we can bring the anterior, the aortic valve anteriorly, so that you have the anterior leaflet here and the posterior leaflet here. And when people look at when they look at the video, they will be able to see this cartoon play, which sort of walks people through how we do that when we're doing the TEE. And we can get this pre-operatively, so you can help to plan for the surgery. Okay, so that's it. We get the biplane view. We zoom on the mitral valve. Okay, and then we're rotating the mitral so that we can get the anterior leaflet to be on top. and the aortic valve is going to be on top here. Left atrial appendage is going to be here, and this will be your posterior scallops.
But secretly, for an experienced cardiologist, do you really get more information from your 3D, or is it just pretty views?
No, I think in terms of there are a couple of things that in terms of better estimation of the LV function, the 3D is definitely been proven to be superior. And in terms, especially in terms of mitral valve disease, mitral valve repair prior to surgery, it's not just pretty views. It's something that you might not see on your 2D. Sometimes you might just think it's prolapse. You don't see a flail chordae, ruptured chordae sometimes, and then you see that on 3D. So yeah, it's there's incremental information from it.
Just being cheeky.